Hello, ladies and gentlemen. Our new public health education program about consultant medical oncology, multidisciplinary oncology, Northern Cyprus, Turkish Cypriot TV channel. Monco 3. This program new subject carcinoma of the esophagus. Carcinoma of the esophagus. Esophageal cancer is relatively uncommon in the United States, with approximately 10,000 to 12,000 cases reported yearly. Unfortunately, in the majority of patients, the disease is often fatal due to its advanced stage at the time of diagnosis. Despite significant advance in operative and perioperative techniques and the advent of variety of novel chemotherapeutic agents, the overall 5-year survival rate remains in the 5% to 10% range. Our source book for this program, Chirurgical Oncology, Contemporary Principles and Practice, and originate of these books, United States. Prevalence and incidence. Squamous cell carcinoma. Squamous cell carcinoma of the esophagus demonstrates a remarkable variability in the prevalence worldwide. The disease is relatively uncommon outside Asia, but is among the leading causes of cancer death in Central and Southeast Asia. A high incidence esophageal cancer belt seems to extend from the Caspian littoral region of northern Iran across the southern republics of Central Asia and into northern China. The highest incidence rates are reported in Iran and northern China. The national mortality rate for esophageal cancer in the People's Republic of China is 19.6 cases per 100,000 individuals for men, and 9.8 per 100,000 for women. The disease accounts for 23% of all deaths from cancer. Some of the areas of highest incidence are in the three northern Chinese provinces of Hunan, Shaanxi, and Hebei, where the average incidence exceeds 100 per 100,000 of population per year. Within the Asian continent, carcinoma of the esophagus is also common in Sri Lanka, in the Indian subcontinent, and among people of Chinese descent in Singapore. In the African continent, its high incidence is found among the Zulu and Bantu tribes of the Cape Province and the Transkei regions of South Africa. Squamous cell cancer of the esophagus is relatively uncommon in most of Europe and the Americas. High incidence areas are nestled in northwest France, mainly Brittany and Normandy, as well as the northeastern regions of Italy. Within the continental United States, the national incidence of squamous cell carcinoma is approximately 6 cases per 100,000 individuals per year and has remained stable since the mid-1980s. Squamous cell carcinoma of the esophagus accounts for nearly 70% of all esophageal tumors in the United States. High incidence rates are observed in the Low Country of the Carolinas and in major metropolitan centers such as Los Angeles, New York, Detroit, and Washington, D.C., where the incidence approaches 28 cases per 100,000. The incidence of esophageal cancer has remained relatively stable among white men older than 30 years, but has nearly tripled over the same period among black men. Esophageal cancer is now the second leading cause of death from cancer among black men younger than 55 years. Adenocarcinoma, no longer a medical curiosity, adenocarcinoma of the esophagus currently accounts for 30% of all esophageal tumors in the United States. Blood and colleagues reported that the incidence of adenocarcinoma of the esophagus and cardia increased at 10% per year during the 1980s, thus exceeding the increases in cutaneous melanoma, non-Hodgkin's lymphoma, and lung cancer. The epidemiologic reasons for this rising incidents are unknown but are likely related to the reported increased incidence of Barrett's metaplasia, a known premalignant condition. The incidence of malignant degeneration in patients with Barrett's esophagus is estimated at 1 in 200 persons per year of follow-up. These estimates are 30 to 40-fold higher than the expected incidence of esophageal cancer among Caucasian men in North America. The incidence of esophageal adenocarcinoma may be underestimated by the apparent dismissal of most tumors of the gastroesophageal junctions as being of gastric origin. Careful pathologic examination of resected specimens reveals evidence of residual Barrett metaplasia in nearly 70% of cases. The combined incidence of adenocarcinoma of the esophagus and cardia is currently estimated at 5.8 per 100,000, ranking this tumor among the top 15 cancer of white men in the United States. Epidemiology. Squamous cell cancer in the Western Hemisphere. Epidemiology evidence has strongly implicated alcohol and tobacco consumption as predisposing factors for squamous cell carcinoma of the esophagus. Tobacco is one of the important sources of nitrosamines byproducts, which are known as potent esophageal carcinogens. Cohort and case control studies in the United States, Western Europe, and South America show that smokers are at high risk for squamous cell carcinoma of the esophagus. The risk is strongly dose-related, with ex-smokers showing a reduced relative risk compared to current smokers, paradoxically. Smoking does not seem to play an important role in the pathogenesis of esophageal cancer in the high-risk areas of the world, where dietary and environmental factors seem to predominate. The ingestion of the diet containing the high level of secondary amines, such as fermented fish, fungus-infested corn, or pickled vegetables may be a more prominent predisposing factors in the high incidence area of the world. Consumption of alcohol has also been strongly associated with esophageal squamous cell carcinoma in the Americas and Europe. Regular drinkers display an increased hazard for esophageal carcinoma. The combination of smoking and drinking seems to exert a multiplicative rather than an addictive effect. The synergy between alcohol ingestion and tobacco consumption may be secondary to the EASE of diffusion to tobacco-related carcinogens through the esophageal wall by alcoholic beverages. Notably, alcohol consumption does not appear to be an important risk factor in the high incidence areas of northern China and among the Muslim population of northern Iran. Environmental factors believed to predispose to esophageal carcinoma include asbestos or radiation exposure and the ingestion of silica fragments. A possible viral cause has also been suggested when papillomavirus particles were found in esophageal cancer cells. Adenocarcinoma. Among all adenocarcinomas of the cardia and esophagus seen at our institutions, Cornell Medical Center, almost 50% are associated with residual benign columnar metaplasia. In the other patients, benign mucosa may have been completely overgrown by tumor. Carefully histologic examination of specimens resected for Barrett's adenocarcinoma often reveal multiple dysplastic lesions associated with invasive carcinoma. Furthermore, cell cycle studies using flow cytometry have shown that most patients with Barrett's adenocarcinoma have multiple Aneuploid populations that often extend beyond the site of the invasive cancers. These pathologic and molecular findings suggest that the entire mucosal lining is exposed to a carcinogen that may participate cellular transformation. Since most studies have shown that approximately 60% to 70% of patients with confirmed Barrett's adenocarcinoma have a long-standing history of gastroesophageal reflux. The latter has become a prime suspect as carcinogens involved in induction of malignant phenotype. However, the exact component of the refluxate contributing to malignant degeneration is unknown. Recent clinical evidence suggests that patients with combined increased acid and alkaline esophageal exposure are more prone to applications of Barrett esophagus, including dysplasia, than those with acid reflux only. Work in our laboratory has shown that potentially oncogenic effect of both conjugated and unconjugated bile acid in vitro exposure of esophageal cell lines to bile acid resulted in the dramatic induction of the cyclooxygenase 2 gene. Exposure of esophageal cell lines to bile acid resulted in the dramatic induction of the cyclooxygenase 2 gene, an inducible form of cyclooxygenase that has been implicated in the tumor formation in both animals and humans. Furthermore, animal studies have shown that esophageal exposure to unrestricted biliary and pancreatic contents results in the development of a Barrett's-like condition and subsequent adenocarcinoma, despite the experimental evidence demonstrated by in vitro and animal studies. The clinical evidence incriminating reflux in the genesis of esophageal adenocarcinoma remains indirect and largely circumstantial. Different premalignant lesions: Barrett esophagus, achalasia, chronic esophagitis, tylosis, Plummer-Vinson syndrome, causitic strictures. But we would bypass these lesions. Clinical presentation: dysphagia is the presenting symptom in the most patient with esophageal carcinoma. Unfortunately, dysphagia occurs late in the course of the disease. The lack of serosal coat allows the esophagus to distend and accommodate an intraluminal growth without noticeably impeding deglutation. Dysphagia occurs when the tumor encroaches on 60% to 8% of the esophageal circumference. Solid food dysphagia may then rapidly progress to total dysphagia. Odynophagia is experienced by 20% of patients and is occasionally the only symptom. Present chest pain or discomfort unrelated to meals is an ominous sign that may indicate mediastinal penetration. Weight loss occurs in most patients, but cachexia is rarely seen in Western countries. Variety of symptoms may indicate extraesophageal spread of tumor, including the following: hoarseness, secondary the recurrent laryngeal nerve invasion, aspiration resulting from an esophago-bronchial fistule, and occasionally massive hematemesis resulting from major vessel invasion. At the time the diagnosis is made, approximately half of the patients have locally unresectable disease or distant metastasis. Diagnosis: barium swallow esophagoscopy. Staging modalities: treatment, surgical therapy, transhiatal esophagectomy, en bloc resection, and different styles and methodological. Radiation therapy, definitive radiotherapy, preoperative radiotherapy, neoadjuvant therapy, postoperative radiotherapy, preoperative chemotherapy, preoperative chemoradiation. And that's all this subject. Another subject we will be continue neoplasm of the stomach. Neoplasms of the stomach. Introduction. Looseness. 1a. Variety of benign and malignant neoplasm are found in the stomach. The widespread use of endoscopy has increased the detection of gastric neoplasm. Leiomyoma is the most common benign gastric tumor, and the adenocarcinoma is the most common gastric malignancy. Although the incidence of gastric adenocarcinoma has decreased substantially in the United States, it remains a significant problem worldwide. Surgery is the primary treatment for most gastric neoplasm. Although novel chemotherapy regimens have produced significant response rates for patients with advanced gastric adenocarcinoma, the result of well-designed clinical trials are required before adjuvant chemotherapy can be incorporated into standard clinical practice. Knowledge of the molecular biology of gastric cancer is still in its infancy, but future molecular-based diagnostic and therapeutic approaches may provide some optimism in the management of the challenging malignancy. Polyps. Gastric polyps are relatively rare compared to colonic polyps. Although gastric polyp may be the source of gastrointestinal blood loss, most polyps are discovered incidentally by endoscopy or by radiologic evaluation of the stomach. Gastric polyps are classified histologically as hyperplastic inflammatory or adenomatous. Hyperplastic gastric polyp account for 75% of all gastric polyps hyperplastic polyps are not true neoplasm, but represent a regenerative response to injury, and therefore they have low malignant potential. Inflammatory polyps are usually located in the antrum, and they consist histologically of the fibroblast matrix with infiltrate. Inflammatory polyps have little or no malignant potential. Adenomatous polyps are true neoplasm with distinctive malignant potential like their colonic counterparts. Adenomatous polyps are classified histologically as tubular-villous or tubulovillous. Poor villous adenomas of the stomach are very uncommon. The incidence of malignancy in an adenomatous gastric polyp is proportional to size, with polyp larger than 2 cm having a greater malignant potential. Adenomatous gastric polyps may be associated with the polyposis syndromes such as familial adenomatous polyposis, Gardner syndrome, and Peutz-Jeghers syndrome. Complete endoscopic polypectomy is the treatment of choice for most adenomatous gastric polyps. However, large polyps and multiply polyps may require gastric resection. Adenocarcinoma. More than 90% of gastric malignancies are adenocarcinomas. In this country, gastric adenocarcinoma has traditionally been considered a highly lethal malignancy with little chance for cure. The consistently poor 5-year survival rate for gastric cancer during the past 25 years has fueled this pessimism. The delay in diagnosis of gastric adenocarcinoma in this country has resulted in an overall 5-year survival rate of 10% to 15%. On the other hand, the incidence and age-adjusted death rate of gastric cancer in the United States have decreased substantially in the last 60 years. In 1930s, there were approximately 30 gastric cancer deaths per 100,000 in this country, whereas in 1990 this rate decreased to 6 and 3 per 100,000 for males and females, respectively. This rate compared favorably with the 65 to 70 gastric cancer deaths per 100,000 in Japan, Chile, and Costa Rica. In contrast to the poor survival statistic in the United States, the 5-year survival rate for gastric cancer in Japan is greater than 50%. The improved survival rate is primarily the result of early detection, with approximately 40% to 50% of all gastric cancers diagnosed as early gastric cancer. Tumor confined mucosa and submucosa with a 5-year survival rate of greater than 80%. Risk factors. The factors responsible for the dramatic decline in the incidence of gastric cancer in the country have not been defined. The fact that the incidence of gastric cancer in Japanese immigrants decreases with successive generations that remain in the United States suggests that environmental factors be involved, whether improvements in the nutrition or changes in the socio-economic and occupational conditions have contributed to the declining incidence of this disease remain speculative. A number of factors are associated with an increased risk for development of gastric adenocarcinoma. Adenomatous gastric polyp may be considered premalignant and they should be completely removed. Patients with a history of gastric polyp should also undergo periodic radiologic or endoscopic surveillance. Patients with chronic atrophic gastritis, pernicious anemia, and patients who have undergone a prior gastric resection 15 to 20 years previously may be at increased risk of gastric adenocarcinoma. Some investigators have proposed pathways from injury to chronic atrophic gastritis with intestinal metaplasia as a maladaptive response progressing to dysplasia and finally invasive carcinoma. Although the precise risk of gastric cancer is not well defined, patients with pernicious anemia are definitely at increased risk and may benefit from periodic endoscopic surveillance. Whether the frequency of carcinoma is increased in the gastric remnant following gastric resection for benign disease remains controversial. Therefore, routine endoscopic screening of the post-gastrectomy patient is probably unwarranted. Nevertheless, the presence of symptoms referable to the upper gastrointestinal tract warrants immediate evaluation in the group of patients. Endoscopic screening of the general population is not cost effective because of the declining incidence of gastric cancer in the United States. The frequency with which cancer arises in the benign gastric ulcer is probably less than 1%. Nevertheless, the presence of non-healing gastric ulcer should raise the suspicion of malignancy. The old age cancer frequently ulcerate, but ulcers never cancerate. Holds true in the other words, a non-healing gastric ulcer was probably malignant from the outset. The gram-negative microaerophilic spiral bacterium Helicobacter pylori is involved in the pathogenesis of peptic ulcer disease. The prevalence of these organisms in patients with chronic, the gram-negative microaerophilic spiral bacterium Helicobacter pylori is involved in the pathogenesis of peptic ulcer disease. The prevalence of this organism in patients with chronic atrophic gastritis and gastric adenocarcinoma suggests an association between Helicobacter pylori and gastric adenocarcinoma, but the causal relationship has not been established. Potential oncogenic mechanism of action for Helicobacter pylori are speculative. It is unlikely, however, that the bacterium is a direct carcinogen, but rather act as a promoter in the complex process of gastric carcinogenesis. Further studies are needed to determine if antibiotic treatment of Helicobacter pylori reduces the subsequent incidence of gastric adenocarcinoma. In the absence of the specific recommendations of screening, high-risk groups, clinicians should make individual assessment of high-risk patients to determine the need for endoscopic or radiologic investigation. The lack of tumor markers specific for gastric cancer makes it unlikely that clinicians in this country will be able to diagnose gastric cancer at an earlier stage, particularly in an era of cost containment and managed competition. Pathological findings and staging. Molecular biology, surgical planning, so many detailed diagnoses and drawing stomach, surgical technique, multimodality therapy, modal therapy, lymphoma. Although primary gastric non-Hodgkin lymphoma is the second most common malignant gastric tumor, it only accounts for 5% of all gastric malignancies. Unfortunately, however, the incidence of primary gastric lymphoma is increasing. The stomach is the most common site of primary extranodal non-Hodgkin lymphoma, and the stomach may also involve secondarily by systemic nodal lymphoma. Symptoms related to gastric lymphoma include early satiety, vague epigastric pain, and obstructive symptom and weight loss. Patients with gastric lymphoma may also present with constitutional symptoms such as fever and night sweats. And continue. Mesenchymal tumors. The stomach is the site of 50% of gastrointestinal stromal cell tumors. Leiomyomas are the most common benign mesenchymal gastric tumors. They usually present as solitary, well circumscribed submucosal gastric masses. Most of these tumors are asymptomatic, but large lesions may produce symptoms of obstruction and hemorrhage. And continue. Carcinoid tumors Gastric carcinoid tumors account for only 2% or 3% of all carcinoid tumors. Carcinoid tumors rise from the enterochromaffin cells of the gastric epithelium, since gastrin mitogen for enterochromaffin cells, and continue. Metastatic tumors, extragastric malignancies infrequently metastasize to the stomach. Some of the more common tumors that may secondarily involve the stomach include melanoma, breast cancer, and lung cancer. The treatment of tumors metastatic to stomach is almost always palliative and is dictated primarily by the presence and severity of symptoms. That's all this program, and we will be continue different subjects of public health education programs about consultant medical oncology, side of multidisciplinary oncology. This program series will be continued surgical oncology, and later a screening program and different subjects will be continued. Thank you so much. Thank you very much. You are patient. See you later, and love from us to all of the world, citizens, people, countries, from North Cyprus, Turkish Cypriots, Northern Cyprus, Turkish Cypriot TV channel, Monco Tres Free Multidisciplinary Oncology. Thank you very much.